the recording the other day. Oh, God. Oh, Lord, honey. It's like cornbread country comes to town. It is not pretty. I apologize for you all because you're probably like, Lord have mercy, it's like nails on a chalkboard. Okay, so this is the COPD assessment test website. Used to, this little guy didn't come up here, but if you click this, if you live in the United States, it's basically going to tell you, like Will said yesterday, that it's not usable for U.S. residents right now. That's because there's this committee through GlaxoSmithKline who are trying to revamp the test for use in the United States. I don't know why it's different here. However, for that reason, they've kind of like shut it down, and I don't know why. We would still use this. I would still use it. So if you just pretend like you're from somewhere else, it's pretty easy to do. Just take the test. Look at all these languages. Does anybody speak anything else? We want to try it in a different language? Better do it in English. I barely speak that. Okay, so you could see how easy this is. A patient could do it at home, or you could do this in the clinic. So you just put their little name in here. So I'll say Jessica, fresh hour, today's date, and then I just go down this little guy and answer all my questions. I never cough. I cough all the time. No phlegm. Phlegm is always there. So you just kind of go down your little check there. And so let's just click some in to see kind of what it looks like when you get a score. I'm just making some of these up. Okay. So click here to get your score. And this little box pops up for them to say basically what impact that symptom level has on their quality of life, like they shouldn't already know. And then kind of like a very traditional, you should consult a healthcare professional about that. So, you can do that really quickly. It takes like 5 minutes. There's this thing that you'll see if anybody's looked at some of the respiratory studies. I know that some people were telling me they had to do that just recently for Dr. Mueller for, for like the, what do y'all call it? IPPE. There's this thing in there called the St. George's Research Questionnaire, and it's like forever long. It takes like 40 minutes to administer it to a patient, and only clinicians can do it. So it gets done in like studies oftentimes, but it's very cumbersome for clinical practice. So that COPD assessment test is kind of like the cousin of that test, and it correlates very well. So that's why it's real easy to use, and it actually has some validity compared to like the gold standard test that we use in clinical settings. Okay. One more thing, and then we'll get through the cases, I promise. I wanted to mention so that you guys don't say I didn't tell you. We talked about causes of COPD primarily being smoking, right? Or air pollution, air irritants kind of thing. There's another thing that can cause COPD. Alpha-1 antitrypsin. Hold on. Trypsin. Alpha-1 antitrypsin is an enzyme that basically is like a buffering system in the lungs to protect them against damage. So any kind of irritation or inflammation in the lungs, we have this. It's like an elastase, basically, and it helps keep the lungs pliable and healthy. People who have a deficiency, they have an alpha-1 antitrypsin deficiency, are people who can develop COPD very early in life. So primarily, like 20 to 50 years old is usually when these patients are diagnosed with COPD, and they don't even have to have a history of smoking for that to happen. So you can have a 30-year-old that walks in with COPD, has never smoked a day before in his or her life, and it's maybe because of this alpha-1 antitrypsin deficiency. It's not a big cause of COPD. I think it accounts for like 10 to 15% of all cases, so very small incidence. And around here, it's almost always because people are smoking. But I know for a fact there's a couple of patients at the Kingsport Clinic that do have this specifically, and that's the reason why they have COPD. So just FYI, didn't want to let you guys go away and not have heard that term. But you treat it just like you treat any other COPD, so it really doesn't matter what the cause is, okay? All right, let's talk about our little cases here. So I'm not going to pull it up. Well, maybe I should. But let's see if I can. So that first patient, 65-year-old female, 50-pack year history. Basically, this patient's coming in today and needs to be diagnosed with COPD, right? Oh, this is an older version, but it'll still work. Okay. All right. So 50-pack year history. Presents with chronic cough that's waking her up at night and also has difficulty catching her breath. Past medical history or pertinent medical information is provided there for you, all her diagnoses and everything, her medication she takes at home. You guys know now how to treat all those disease states, so you should be good. Let's see, smoking, 1 pack a day for 50 years. Lives with a husband and 5 cats, no alcohol or illicit drug use. So the resident decides to do spirometry on this patient because that's diagnostic of COPD, and he has a hunch that maybe this patient has COPD, and this is what you come up with. So a couple things to look at here: age, weight, height. Those are the things that give us the reference. Okay, so when you see there in your boxes all your references, that's all based on the fact that she's a female and she's 5'5", and she's 65 years old. Okay, and those are charts, just like BMI charts. So you don't have to know that stuff. It's just, it'll tell you, here's the reference. Like any other lab value has a reference. Okay. So, does she have COPD? What do you guys think? Yes. Why does she have COPD? What's the diagnosis for this patient? Diagnostic criteria. What's her? What? 0.6, right? Yeah. So her FEV1 is below 70% or below 0.7. So by definition, she has COPD. Okay. What other clinical things tell you she has COPD? Like just what's she telling you about? Chronic cough. She's up at night, having a hard time catching her breath. Right? All those things kind of make you think. And specifically because she has a 50-pack year history. If that same patient came in complaining of those things and didn't have that smoking history, you wouldn't automatically go to COPD, right? But she fits the classic picture. So this is a new diagnosis of COPD. Okay. So, oh, darn it. Sorry. So now, tell me, based on that, everything you need to know about her, everything you have about her, how would you classify her in her gold groups, A, B, C, or D? I heard a B? Yeah? Okay. Oopsie. I'm not very good with this. B? Okay, what makes her a B? Right, so FEV1 was greater than 50%, so she's still here with airflow limitations, but she's symptomatic. How did you guys determine her symptoms, Michelle?
By what she said, how she has a chronic cough that wakens her at night, and there's something else. Not being able to catch her breath when she plays with her grandchildren.
Okay, so you guys kind of used her clinical picture. Did anybody, some people asked me for a CAT score, right? So some groups got 25 for their score, and I gave some groups 9 for their score. So just to kind of like be trickery today. But it just kind of, I really do that not to be mean, and this is all just for kind of learning purposes, but that's just a very clear indication of how level of symptoms can totally change where this patient falls on the spectrum. Because if she had a 9, what did you guys have her for a 9? An A, right? Because it's symptom-based, symptom-driven. Okay? It sounds like her symptoms probably do put her in a B, but I just kind of made that up just to make the point. So either way, if you put A because you had that score, if you put B because you had a different score that I gave you, they're both correct. Did anyone have anything besides A or B that you want to speak up and tell us why? You're like, heck no, I don't want to tell anybody that. Okay, so recommend appropriate initial therapy for this patient, including all aspects of care. So what are some things we want to make sure that our little patient gets before she leaves today? Right, smoking cessation counseling, that's a huge one. What else? Non-farm, let's go through that. Yeah, allergen control, 5 cats, that could be a problem. Oh my gosh, let me tell you. So I'm a dog person. No offense if you're a cat person. But no offense is one of those things you say to people when you're trying not to offend them, but it's like kind of a cover-all. But really, no offense if you have cat people. My aunt just inherited this house from her godmother, and her godmother lived in a house and she loved her cat. Like, she always had a cat her whole life. So I went this weekend to help her move some stuff out of it, and there was like cat hair everywhere, and I about died. I did not know I was allergic to cats, but I clearly have an allergy to cats, so it was not pretty. Okay, so yeah, flu vaccine I heard. What about pneumococcal? Yeah, she's 65. She, let's scroll back up to the top for a minute. She's 65. What if she were 60? Would she still have an indication for a or for a pneumococcal vaccine? Yes, exactly, because she has COPD and she has a heart history, then she would get a pneumococcal vaccine regardless of age, right? Is there any other vaccine that this lady's indicated for at 65? Shingles, yes, definitely. So that's one you want to also give as well and check in on, right? Okay. So we've covered some of our non-farm things. What about pharmacology? What do you want to start? What if you were an A? What did you start if you were in group A? Okay, albuterol as needed. Perfect. What about group B? Heard Advair? Okay, had some Advairs. Anybody argue against Advair or do something different? Yes.
We had just albuterol just as a long-acting without anything else.
Okay, so just one long-acting bronchodilator.
With
Okay.
albuterol as needed.
Okay, yeah, great, as rescue therapy. Yeah, don't forget that. Regardless of where they end up in the category, they always have to have a rescue inhaler. So that's a really important point to make sure that you kind of hammer home. Okay? So this group, why did you guys decide to do a steroid? What was your rationale? I don't think it's necessarily wrong. I'm just curious.
It was recommended for group B.
Well, it had the long-acting beta agonist in it, and I think it was just to reduce, like, inhaler burden down the road.
Okay, so kind of like a preemptive strike against having to up therapy later, right? Okay. I mean, you could make an argument here.
It had a 50-pack-year history, so.
Okay, yeah. I probably personally would not start a steroid in this lady right now, but I don't think that based on the information, and she's made up in my head, so you know, you don't know who I am. You don't know what's going on up here, and trust me, you don't want to know sometimes. But you can't, I think based on what the information you have here, that might be a reasonable choice. So I don't necessarily think it's wrong to start a steroid in this patient. I probably wouldn't start a steroid in this patient. But remember, steroids really start to benefit us in these C and D categories. And patients who are not having exacerbations, typically the risk of a steroid from side effects and from pneumonia and things like that kind of outweighs their benefit. So once they get up here and they're having lots of exacerbations and they have really limited airflow, regardless of their symptoms, steroids are one of the few therapies that have really shown to decrease the rate of exacerbations in patients who are having multiple exacerbations. So that's one of the best things we can do for those patients. So I don't think it's wrong necessarily. I wouldn't do it, but I think that that's kind of one of those things, that's where your clinical judgment comes in, you know. It's a good job. Thank you for sharing that. Anyone else have any other suggestions? Did anybody decide on tiotropium over a beta agonist? No? That's fine too. So, my personal thought on this is, if you think about the mechanism and the pathophysiology behind COPD, there's mucus production, right, and bronchoconstriction and airflow limitation. So I think that for patients that have lots of mucus production when they present, possibly doing an anticholinergic first is a better therapy for them because it has that mucus drying effect. That doesn't make it more right or wrong, but that's kind of one of those things that if I hear that about a patient and they're asking me what to recommend, I'll go with tiotropium over a long-acting beta agonist first as my first bronchodilator. But that's patient specific, so I don't want you to think you have to pick that one over a long-acting beta agonist. That's just kind of a free tip. I guess it's more about guess what I'm thinking, but trying to fill everybody in. Okay, questions about the first encounter? Good. All right, so 2 years later, she comes back. The moral of the story is she's still smoking, even though she's cut back. And she's had 3 exacerbations requiring treatment since her initial diagnosis. Some of the groups asked me what the timeline was for that. She's had 2 of those exacerbations in the last year. You see there that regardless of what you picked for her therapy regimen, she was started on salmeterol and albuterol ipratropium. So that's what she's been on since diagnosis, okay? And they've repeated spirometry today in the clinic because that's what good clinics should do, and do spirometry once a year, even though that doesn't always get done. And so you see her new values there. So did anybody calculate her new FEV1 based on all that? What's her new percentage FEV1? 45%, right? So she's lost quite a bit of lung function. She's gone from 65% to 45% in 2 years. And that's probably a function of all those exacerbations, okay, plus the fact that she has COPD. So I had a group ask me about, the effects. Remember, COPD patients are always going to be declining, okay? Medications change the slope of that decline. So if you have a line that's declining down and we start them on a long-acting beta agonist, the slope gets a little less steep. And so they decline at a slower rate, but they're still going to decline, okay? The one thing that can almost slow the decline to nothing is stopping smoking. That's the best thing they can do. So I was telling a group that, normal patients, we talked about yesterday, lose about 40 to 60 mLs of FEV1 per year. Patients who have COPD who stop smoking lose about 80. Okay, so that's still about twice as much as a normal person loses. But a person who has COPD and continues to smoke loses between like 120 and 150. So it's almost double the loss of lung function per year if they continue to smoke. So just kind of FYI on what a difference that can make. The other thing I wanted you guys to notice, and you may or may not have noticed here, this lady has lost 20 pounds in 2 years. And for lots of patients, especially she has diabetes, type 2, she has hypertension, she has GERD, she has lots of comorbidities that would make you think this lady shouldn't lose weight, right? So that would be something you need to ask her. Have you been trying to lose weight? Okay? Because she may be unintentionally losing weight because her disease is getting so much worse. So that's what, a 10, like a 12% loss, I think, something like that. So that's a pretty significant weight loss in a little bit of time. Okay, so I told you guys if you asked on this one, her CAT score was 30. Okay, so her symptoms, regardless of what CAT score you got in the beginning, her symptoms have gotten a little bit worse, or a lot worse. So there were some other things you guys had asked about in this question. I forget what it was. Did anybody else ask me other questions about this one? Oh, like symptoms, like what kind of symptoms she was having. I had somebody ask me about that. So I just said that she was, it was waking her up several times a month. She had pretty much stopped playing with her grandkids because she just couldn't stand being out of breath anymore. She had stopped all of her hobbies, activities. She didn't like to get out in big crowds because she was afraid of becoming short of breath. Those things happen a lot to these patients. Let's see. Okay, any other questions about that one? All right, so I'm just going to leave it on the case here. So based on her new classification, what should her primary goal of therapy be?
Reduce exacerbations.
Reduce exacerbations, exactly. So she's now a C or D, right, regardless of her symptoms. She's a D, really, because she's having that high CAT score, and her FEV1 is 45%, and she's had 2 exacerbations in the last year, at least. Okay, so she's now in the D category. So reducing exacerbations, that's the primary goal. let's see. What else? We talked about this. Like, I beat it into the ground. Single most important thing she can do: stop smoking. Right? Enough said. What therapy changes would you make to better care for ML's COPD if you wanted to make changes at this time? So what are some options we can do? So she's on salmeterol and albuterol ipratropium. So somebody just shout out something you did. Tell me. Or didn't do.
We changed the ad there.
Okay, so you wanted to add the steroid. Okay, perfect. So we went from salmeterol to Advair, which is salmeterol plus fluticasone. Perfectly good choice. What did you guys pick a dose?
We said the 250 or 50.
Yeah, awesome. So common thing I see happen, especially in resident clinics, is they'll I want to start low with the steroid. I'm afraid to give them too much. I'll start low and work their way up. Remember, those low dose steroids are for asthma patients. We use higher doses in COPD patients. So 250 or 500 is where we should be starting in therapy. Any other thoughts? Anybody do anything different? You could add tiotropium to salmeterol and not do an inhaled steroid. Okay, that's another option you could do. What specifically about this patient makes adding a steroid a better option than doing this? I'm sorry? No, remember, tiotropium's long-acting. Oh, yeah, sorry, they're on. Well, yeah, you could stop that one. Yeah, sorry. But other than that, thank you. I'm so glad you guys picked that up. Thank you. Very good. Yeah, so she's on that. We'd have to stop that. But, technically this is a long-acting option we could add. But what makes a steroid better for this patient specifically? Right. That's the whole purpose of a steroid, is to stop those exacerbations, right, or to help reduce them. And she's already having lots of them. She needs that anti-inflammatory effect that you get with steroids. So I agree. I think adding a steroid is a better step in this patient than going to tiotropium. Did anybody want to add like Daliresp or any other therapies that we talked about? Anything? No? Okay. Yeah, I think that's totally fine, going to salmeterol. Did anybody want to do triple therapy? Did anybody say I want to do Advair plus tiotropium?
We said after prescribing these new medications and assessing her adherence and also continuing encouragement for smoking cessations to possibly reassess for triple therapy at the next.
Yeah, awesome. I think that's great. Yeah, I think it wouldn't necessarily be wrong at this point, but it's worth just doing one medication at first to see the effect we get and then adding a second one if we need it. So will she probably need it over the course of her life? Yes. Okay. Just remember, like you guys said, if you did say tiotropium, make sure you get rid of that ipratropium out of the COMBIVENT and just do a ProAir or an Advair inhaler. I had somebody ask me earlier today, any questions about that one? Okay. I had somebody ask me if you would be expected to know brands on the exam. I would hope you could pick out like common brand names. Like Q-Bar is beclomethasone. I would hope you could pick out Advair is salmeterol and fluticasone. However, I only put generics on the test. Okay, so you need to pick up categories of drugs and know what they do. But you also, remember, will be responsible for knowing doses. So you have to be able to use that chart, low, high, medium dose steroids for asthma, and then know you need a higher dose steroid for COPD. Okay? If you have questions about that, just let me know. Okay, our next patient, RT, is a 58-year-old male admitted to the hospital for a COPD exacerbation. According to his wife, he was doing great until 3 days ago when he started to have symptoms that looked a lot like a cold. Okay? He quickly developed increased shortness of breath. I don't know why that says that started, but fever and a productive cough. Information about RT is listed below. So that's his past medical history, as well as his medications he takes at home, his vital signs on admission. He's allergic to peanuts. 65 pack year history, but quit 2 years ago. lives with his wife and a college-age son, and he is disabled secondary to an MI in 2008. So he's out. He's not in the workforce. All right. So the ER physician has no idea what to do, so you've got to help save this guy. It's not going to be pretty if you don't step in. So, what's our first? Recommend initial orders for RT to treat his COPD exacerbation. So what are some things that you guys wanted to do therapy-wise for him? So his home COPD medicine is Spiriva. Tropium, and he's got albuterol. PRN for his COPD specifically. So how do you want to treat his exacerbation?
Prednisone.
Prednisone, awesome. Did you guys pick a dose?
40 milligrams, I think is what we put.
Yeah, like I said, that's what the guidelines say. Prednisone 40 milligrams a day times 5 days. That's what the guidelines would say. We don't know enough about this patient to know if he needs a longer course, if he needs a higher dose. So pretty much any steroid dose, as long as it equals at least 40 milligrams of prednisone a day, is not wrong. What else?
We continued his Spiriva.
Okay, continued Spiriva. I think that's totally fine. So I would continue all home meds, really. You know, you continue, most of those. So continue. Did anybody want to hold the beta blocker?
We changed it to that's selective.
Okay, so you changed it to metoprolol for selectivity. That's fine. I had several groups ask me about that, and very appropriately thought about the beta blocker thing. And what I think in this situation, you don't know enough yet to know like if that's affecting the patient or not. Just from what you have on the paper. But it's definitely a thought to keep in the back of your head. So it's definitely not wrong. It's a great thought. But this might be a patient who's totally fine on carvedilol too, and just for another reason is having this COPD exacerbation. But that's really good. So beta blocker, we'll just put your question mark. What else?
We threw on azithromycin.
Awesome. Okay. What dose did you guys pick?
We just did 250 IV for 10 days.
Okay. And you can do that, but we normally start with 500. So I always, if you can ever make a difference in somebody's azithromycin use, please use 500. Because 250 is kind of a low dose, and it helps breed resistance daily times 5 days. I know that the package insert probably says 250 is fine for this patient, but it's just kind of one of those things. A little more azithromycin is a little better than not enough. Anything else you guys want to do acutely?
Oxygen.
Okay. Oxygen, yeah, because his pulse ox is 85%, so O2, right? With a goal pulse ox of 92 to 94% usually. The guidelines actually say even lower than that. They say like 89 to 92%. But what about bronchodilators? What do you guys want to do? This guy's coming in, he's acutely short of breath, he can't breathe. He's already taken his Spiriva at home, he's taken his his albuterol, it's not working. Thank you. So this patient might need a nebulizer of like albuterol and ipratropium if we're going to stop the tiotropium, or just albuterol, right? So yeah, don't forget short-acting bronchodilators acutely during an exacerbation because they're going to need that. So I'll just say short-acting beta agonist, nebs, as needed. Anything else on this one we're missing? I think that's good. Don't forget that azithromycin on top of being,
What was the dose on for the nebulizer with the albuterol?
3 milligrams of albuterol and
Do what? I'm sorry.
3 milligrams of albuterol and half.
Yeah, and a half. So it depends on the concentration. So there's like a 0.083%. There's like a do 5%. And usually it's just, if there's a protocol and it's that percentage, and you just do one of the ampules in the nebulizer. So it's either like 2.5 milligrams or 5 milligrams, depending on the percentage. It's what the patient ends up getting. So it's based on percentages, like of the solution. Is that good? Okay. Let's see. Okay, so he survives this exacerbation, and he's ready to go home. So what kind of changes do you want to make at this point for this patient?
We did, since it was his first exacerbation, and he was already on appropriate therapy.
Okay. Yeah, I had another group in the back that argued the same thing, that they didn't want to make any changes either, based on the fact that he was doing okay as far as we know, and we think this is probably an illness that may have brought on the exacerbation. So I think no change is totally fine. You could do that. Does anybody want to change?
We did, since he already has one admission, like we put him in category D.
Okay, yeah, so you guys counted this as an admission and put him in the high risk category, right? And you said, okay, yeah.
Inhaled steroid.
Okay, so did you add inhaled steroid to the tiotropium, or did you change to like an Advair?
We actually didn't know. We left him on like triple therapy because he's
Okay.
like just got out of a exacerbation. He's at risk of another one,
Okay,
but we didn't think either one was wrong.
We just added that there.
okay, that's fine. Yeah, again, I think with the information you have here, it's ambiguous for a reason, because I want you guys to realize that there's lots of different paths this could take. So I don't think either of those choices are necessarily wrong. He definitely he's now category D if we count this admission as an exacerbation, which it is. And so you could make the argument to change therapy based on that. Any other questions? Did we get all the questions? That was it, right? Okay. So this is it. Right? Well, you guys have Dr. Odell for pulmonary hypertension and a couple other things coming up. And then we have one day that's kind of a review day. So we'll be here during that time to answer any questions you have on the material. And let me know if you have specific questions about this.
I'll go ahead and send that out.
Yeah, prednisone and prednisone, they're one-on-one. Typically, and this is not necessarily wrong, but a dose that high would probably have to be broken up several times a day. So in that situation, as a GI, like if you give somebody much more than
We have time.
about the most you give a person of prednisone at one time is 60 milligrams. Anything more than that, in one dose, you work it up. So in that situation, I think that's a good thought to give more than 40 milligrams. And you might want to do hours with prednisone. Yeah.
Okay. With the FPV, like when you categorize them, mild, moderate, or
Oh, that happened to me. You like run out of both? Both of them?
I don't know if you want to
So if they have the ratio of less than 0.7, that's never going to change. Like once they have that and they have COPD, the ratio is there. That's their diagnosis. So then it's just a matter of how is their FEV1 problem. So the first time, so even with the new ones, the diagnosis of COPD is the FEV1 over FVC ratio of less than 7%. So that's diagnostic. But then the categorization is about their FEV1 over the reference.
Okay, so after we know that they have COPD, we use the percentage.
Yes, you'll use the percentage divided by them, divided by the reference, to figure out where they fall in their air quality. Yeah, you got it?
Yeah.
Perfect, no problem.
Like if I go to one of them, they're like, go ahead.
Yes. Remember how many you did?
No, some people will raise them then. Getting plugged, and that's why it's like on that little around, and then it's well, it could be like you was plugged out of it. Like that's one of the big diagnoses. It's like they have this overproduction. You can have some really like adult it's more likely to happen even later in life. And things like that. So it's probably worth getting checked out. If nothing else, I'll start. I don't know. I've probably had it for a really long time, but now that I was probably in the past year.
So we're not talking a couple of weeks here, we're talking another last.
Yeah, I did check it out because you know they're so tough. Like I noticed like all the times like I'll lay down after we get done and it'll cut off so I don't have all over stuff or something. Yeah, you need to get that checked out because you may just have a low level asthma, you know, like a low dose steroid yourself, or even just the pain over it sounds like it could be something, which I think the mucus really is meant to be like
Occasionally I recently found myself on
but it's not noticing you burn all the time. Yeah, I mean, uncontrolled GERD can cause that kind of stuff too, that mucusy, but
I just wanted to ask you beforehand. I was curious.
yeah, well,
And I thought that for a while. I went, well, no, it's not.
well,